Hello, my name is Shania, and I work in the CVICU, and today we will be talking about Hemodynamics 101. What is hemodynamics? By definition, it is the study of distribution of pressures and flows in the circulatory system. I think the best way for us to get started is reviewing some anatomy of the heart and flow. We have deoxygenated blood from the body entering from the inferior and superior vena cava entering into the right atrium. Blood then passes through the tricuspid valve into the right ventricle. From there, it will ascend into the pulmonary artery through the pulmonic valve into the lungs to be reoxygenated. From the lungs, the blood will enter through the pulmonary veins into the left atrium. It will pass through the mitral valve into the left ventricle. Finally, it will pass through the aortic valve into the aorta to be redistributed to the body. With this flow, our hearts can distribute blood, nutrients, and oxygen to every organ of our bodies. Two major forms of hemodynamics that we most commonly see are blood pressure and heart rate. We see blood pressure as systolic pressure over diastolic pressure. Systolic pressure is measured by the pressure on the arteries while the heart is contracting or in systole. Diastolic pressure is the pressure when the heart is now at rest and filling or in diastole. This is during one heartbeat. But what is physically happening to create these numbers? It is important to understand the factors needed to create the perfect flow, and these are the electrical conduction of the heart and pressure gradients. So today we're going to discuss the cardiac cycle. Now some people start with the isovolumetric ventricular phase. However, I like starting with the atrial contraction, thinking in terms of flow and starting with the full ECG beat. So we start with the P wave that represents atrial depolarization, and thus leads to contraction of the atria. This is initiated by the firing of the sinoatrial or SA node located on the upper wall of the right atrium. This increased pressure then sends the blood down to complete the filling of the ventricles. It's important to remember that a pressure gradient means blood moves from a higher to lower pressure. Therefore, the ventricles already hold blood from the tricuspid and mitral valves, or AV valves, from being open. During this time, the SA node has sent the signal to the atrioventricular or AV node, and the AV node slows the electrical conduction to allow filling time in the ventricles. After the ventricles are full and atrial pressure has fallen, this forces the AV valves to close. Thus now we are at the beginning of systole, and starting with the isovolumetric phase when all the valves are closed and into ventricular depolarization in the QRS complex on the ECG. It is considered isovolumetric due to no changes in volume in the ventricles. The ventricles must then contract to overcome the semilunar valves, or the aortic and pulmonic valves, resistance to allow them to open. The signal is sent from the AV node down to the bundle of His, which then branches to the left and right bundle branches, one to the left and one to the right ventricle. Once this occurs, the ventricles contract and the resistance is overcome and the semilunar valves open, leading to rapid ventricular ejection and blood from the ventricles, and this occurs during the ST segment on the ECG. We then enter beginning ventricular repolarization, causing reduced ventricular ejection. This is shown at the onset of the T wave on the ECG. Thus the name of the phase. There is a rapid decrease in pressures in the ventricles, leading to reduced ejection. When the ventricular pressures have dropped below aortic and pulmonary pressures, the semilunar valves then close, marking the end of systole, and the beginning of diastole, relaxation and filling. This is the isovolumetric relaxation phase and follows the T wave on the ECG. Negative pressure created in the ventricles become lower than the atrial pressure without volume changes. During this time, the atria are in diastole and filling. This leads to rapid ventricular filling phase, and the AV valves open and the ventricles start to fill until the pressure is equal in the ventricles and atria, leading to AV valves to close. Finally, we have circled back around to the beginning, but the end of diastole, leading to atrial contraction to finish filling the ventricles. The cycle then continues to repeat. And now we are back to this slide and talking about heart rate. Cardiac output is the amount of blood ejected from each ventricle in 1 minute, mainly the left ventricle, written as liters per minute. The two factors that make up cardiac output are heart rate and stroke volume. As we know, a normal heart rate is 60 to 100 beats per minute. If the heart rate is increased, this can cause the heart to have less time to fill during diastole, leading to a decreased cardiac output due to less blood being pumped out. If the heart rate is decreased, the heart may have too much time to fill during diastole, stretching the heart muscle or myocardium, leading to the heart to become weaker and unable to effectively pump out all of the blood. This will also lead to a decreased cardiac output. Reasons why physical exercise is important to build a strong heart. Stroke volume is the amount of blood ejected from the left ventricle in one heartbeat. Normal range is 60 to 100 mils per beat. The calculation is the difference in end diastolic volume, the amount of blood in the ventricle at the end of diastole, and end systolic volume, the blood volume in the ventricle at the end of systole. A common term we hear is ejection fraction. This value is stroke volume represented as a percentage of the volume of blood that is ejected from the ventricle at the end of systole. Normal for the left ventricle is greater than 50%. There are three main factors that go into producing stroke volume. They are preload, contractility, and afterload. Preload is the amount of myocardial stretch and the amount of volume at the end of diastole in the left or right ventricle. We can indirectly determine ventricular preload by measuring the pressure required to fill the ventricles. The two measurements we'll focus on are central venous pressure and pulmonary artery wedge pressure. Central venous pressure is measured 2 to 8 millimeters of mercury and is used to assess right ventricular preload. It is measured in the right atrium of the heart, typically with a Swan-Ganz catheter. If the right ventricle isn't effectively pumping and emptying, the right atrium and superior and inferior vena cava will back up and cause a higher pressure. We will discuss this when we make our critical care course video, but this is why jugular vein distension occurs in right heart failure. Pulmonary capillary wedge pressure is measured 6 to 12 millimeters of mercury and is used to assess left ventricular preload. It is also known as pulmonary artery occlusion pressure, as a balloon at the end of the Swan-Ganz is filled and occludes a pulmonary artery. This measurement of the pressure within the pulmonary artery indirectly represents the pressure of the left ventricle because it is briefly not allowing forward flow, and the backflow from the left ventricle, left atrium, and lungs represents the end diastolic filling of the left ventricle. For example, if the left ventricle is ineffectively emptying and through the next cycle is filling even more, the pressure will be higher. Afterload is defined as the resistance or pressure the ventricles must work against to eject the blood during systole. Afterload is measured in pulmonary vascular resistance and systemic vascular resistance. Vasodilation and vasoconstriction can be two main contributors to afterload. Pulmonary vascular resistance is afterload or resistance for the right ventricle. This is the impedance of flow by the pulmonary vascular system. Systemic vascular resistance is the afterload or resistance for the left ventricle. This is impedance of flow by the peripheral vascular system. Contractility, also known as inotropy, is the myocardial muscle fibers to shorten or contract. Stroke volume is thus affected by how well the heart can contract and the ventricle's compliance or the amount of stretch when the ventricles are filled. This is the case where physical structure and strength are highly important. Contractility, also known as inotropy, is the myocardial muscle fibers shortening or contracting. Stroke volume is thus affected by how well the heart can contract and the ventricle's compliance or the amount of stretch when the ventricles are filled. This is the case where physical structure and strength are highly important. Pulmonary artery pressure is the pressure in the pulmonary arteries in the lungs. Pulmonary artery systolic pressure can represent right ventricular systolic pressure because there is a common chamber with a common volume and pressure. However, pulmonary artery diastolic pressure can closer represent left ventricular and diastolic pressure when the mitral valve is open due to no obstruction between the pulmonary artery and left atrium. This is why pulmonary artery diastolic pressure may be used to approximate pulmonary capillary wedge pressure when you are unable to wedge or inflate the balloon to occlude the pulmonary artery. Cardiac index allows us to determine a cardiac output more specific to the body size of the individual. To determine cardiac index, we must know the patient's weight and height to determine body surface area. Thank you so much for watching my lecture today on hemodynamics. Look forward to our videos on critical care to learn more about disease processes affecting hemodynamics.